Lisinopril is one of the most prescribed medications in the world. Over 100 million prescriptions are written for it every year in the United States alone. It is prescribed for blood pressure, for heart failure, for protecting the kidneys in diabetic patients. It is well studied, widely trusted, and for most of the people taking it, genuinely beneficial. And right there in its FDA prescribing information in the section listing adverse nervous system effects is a term that almost nobody taking this medication has ever been told about. Peripheral neuropathy, including paresthesia and dysesthesia. Tingling, burning, abnormal sensation in the extremities. Right there on the label. There is also something the label does not explain, something that requires understanding what lisinopril actually does inside your body at a chemical level that goes beyond lowering blood pressure. Lisinopril works by binding to a zinc-containing enzyme. And what it does to zinc over months and years of daily use is a story that almost no one on this medication has ever heard. I am Dr. Mary, and today I am going to show you exactly how lisinopril affects two systems in your legs and nerves after 60 and what the right monitoring looks like. Lisinopril belongs to a class of medications called ACE inhibitors, angiotensin-converting enzyme inhibitors. ACE inhibitors protect your cardiovascular system in ways that are well documented and genuinely important. They lower blood pressure by relaxing blood vessels. They reduce the workload on the heart. They protect the kidneys in people with diabetes or heart failure. For many people over 60, lisinopril may be exactly the right medication, and stopping it without medical supervision would be a serious mistake. What this video is about is not stopping lisinopril. It is about understanding two specific effects this medication may have on your legs and nerves that are almost never discussed at the point of prescribing, and what to ask for if you have been on it for years. Stay with me through the mechanism section, because once you understand how lisinopril interacts with zinc at the molecular level, the nerve symptoms some people on this medication develop will finally make sense. I want to tell you about a woman I will call Patricia. Patricia was 68. She had been on lisinopril for 7 years, prescribed for hypertension in her early 60s. Her blood pressure was well managed. Her GP was satisfied. She had no complaints about the medication itself. But for the last 2 years, Patricia's hands and feet had not felt right. Not numb exactly, more like the sensation you get when a limb falls asleep, that faint, persistent tingling at the tips of her fingers and around her toes. It was there when she woke up. It faded during the day, but never entirely went away. She mentioned it twice to her doctor. The first time, he told her it was probably carpal tunnel from the way she slept. The second time, he ordered nerve conduction studies. The results were borderline mild sensory changes, nothing diagnostic. He told her to watch it and come back if it worsened. Nobody asked about her zinc level. Nobody connected the tingling to the medication she had been taking every morning for 7 years. Patricia was not on metformin. She was not on a PI. She did not have diabetes. She had no obvious explanation for nerve symptoms that had been building for 2 years. What she had was a medication that works by binding to a zinc-containing enzyme, and that, according to peer-reviewed research, may gradually deplete zinc levels in some patients over time. And zinc, as I am about to show you, is not a minor nutrient for your peripheral nerves. Here is what lisinopril does at the molecular level and why zinc is at the center of it. The enzyme that ACE inhibitors block, angiotensin-converting enzyme, is a metalloprotease. That means it requires a metal ion to function. In the case of ACE, that metal ion is zinc. Zinc sits in the active site of the enzyme and is essential to its catalytic activity. ACE inhibitors like lisinopril work by binding directly to that zinc ion in the enzyme's active site. They essentially occupy the position where the zinc would otherwise participate in the chemical reaction blocking the enzyme and preventing it from converting angiotensin Y to angiotensin II. This zinc chelating mechanism is precisely why ACE inhibitors are effective, but it also means that these medications have a chemical affinity for zinc that extends beyond just the target enzyme. Research published in the Journal of the American College of Nutrition found that long-term treatment with ACE inhibitors, captopril and enalapril, led to measurable decreases in zinc levels in patients with hypertension, with the proposed mechanism being increased urinary zinc excretion, driven by the medication's zinc chelating properties. This depletion is not guaranteed, and it is not dramatic in most people, but it is documented. And in someone over 60, where zinc absorption from food is already declining with age, and where the baseline zinc status may already be marginal, a medication that adds a consistent zinc depleting effect over months and years is worth understanding. Because zinc is not a peripheral nutrient for your nervous system. It is a central one. Zinc is required for the synthesis and maintenance of myelin, the insulating sheath around your nerve fibers that keeps signals traveling cleanly. It is involved in neuronal signaling throughout the peripheral nervous system. And zinc deficiency in older adults is well documented as a contributor to peripheral sensory changes, the tingling, the burning, the abnormal sensations in the extremities. The FDA label for lisinopril separately lists peripheral neuropathy as a reported adverse nervous system effect. Whether the zinc pathway is the mechanism responsible in a given patient or whether another process is at work is a question the research has not fully resolved. What is established is this: long-term ACE inhibitor use may deplete zinc, and zinc deficiency can impair peripheral nerve function. Both facts are documented. Both are worth monitoring. And in someone with years of progressive sensory symptoms on this medication, both deserve to be named in the appointment. Stay with me, because the second mechanism is the one that confuses most people on this medication. Lisinopril does not just take something from your legs. For some people, it also adds something. And what it adds is the reason the monitoring looks completely different from everything we have discussed in this series before now. Here is what lisinopril does to potassium and why it matters differently from what most blood pressure medications do. Lisinopril blocks the conversion of angiotensin I to angiotensin II. Angiotensin II normally stimulates the adrenal gland to release a hormone called aldosterone. Aldosterone tells the kidneys to excrete potassium in the urine. When lisinopril suppresses aldosterone, the kidneys retain more potassium than usual. In most people, this mild potassium retention is not a problem, and it can actually be beneficial, particularly for people who are also taking diuretics that deplete potassium. Lisinopril's potassium-sparing effect partially offsets what the diuretic takes away, but here is where it becomes relevant to your legs. When potassium rises above a certain threshold, a condition called hyperkalemia, it disrupts the electrical balance across your muscle and nerve cell membranes. The resting membrane potential shifts. Nerves become more difficult to fire correctly, and muscles, particularly in situations of low blood flow, like the nighttime hours when you are lying flat and circulation to your legs is naturally reduced, can experience abnormal contractions. The result can be muscle weakness. Leg cramping, a heaviness or aching that does not fit the pattern of ordinary soreness. And in more significant cases, tingling or numbness in the extremities, because the peripheral nerves that run to your feet are among the most sensitive to changes in the electrical environment around them. Research confirms that electrolyte disturbances, particularly hyperkalemia, are a documented mechanism by which ACE inhibitors like lisinopril can contribute to leg cramps and peripheral sensory symptoms. The key distinction from what we have covered in previous videos is that this is not a depletion. It is an accumulation, and it requires a different kind of monitoring. Now, Patricia. When Patricia finally had a comprehensive blood panel that included both her potassium level and her zinc status, the picture became clearer. Her potassium was at the high end of normal, not clinically elevated, but approaching the range where peripheral nerve sensitivity begins to shift. Her zinc was below the lower threshold of adequate status for her age group. Neither finding alone was alarming. Together, in someone with 2 years of progressive peripheral tingling on a long-term ACE inhibitor, they told a story that had a plausible explanation and an addressable one. Her doctor adjusted her approach. The zinc piece was addressed with dietary changes and a conservative zinc supplement with her doctor's guidance. The potassium piece prompted a conversation about her full medication list. She was also on a low-dose potassium supplement that had been added years ago without subsequent review, which was contributing to the elevated end of her potassium range. That supplement was discontinued. This is a version of the prescribing cascade we covered earlier in this series, a supplement added to solve one problem, quietly compounding a medication's existing potassium-sparing effect. The supplement was not wrong when it was prescribed. But nobody had looked at the combination again in years. Over 4 months, the tingling at her fingertips reduced significantly. It did not disappear entirely. Some of what she was experiencing may have been age-related changes that are not fully reversible, but the progressive worsening stopped, and the worst of the nighttime foot sensations improved. She did not stop her Lisinopril. Her blood pressure still needed managing. What changed was the monitoring around it and the willingness to ask 2 questions that nobody had thought to ask in 7 years. Here is what those questions are and how to bring them into your next appointment. If you have been on Lisinopril or another ACE inhibitor for more than 2 years and you have tingling, burning, or abnormal sensations in your hands or feet, bring both of those facts into the same sentence at your next appointment. Say, I have been on Lisinopril for however many years and I have been experiencing tingling in my feet. I would like to ask whether my zinc level and my potassium level have been tested recently and whether either of them could be contributing to what I am feeling. That is the conversation. 2 nutrients. 1 sentence. Years of unmonitored effect named directly. On zinc specifically, a serum zinc level is the standard test. Though it has limitations, serum zinc can appear normal while intracellular zinc is marginal. If your doctor is open to it, ask whether a more comprehensive zinc assessment is appropriate given your duration on an ACE inhibitor. Dietary sources of zinc include red meat, shellfish, legumes, nuts, and seeds. If supplementation is considered, zinc should always be accompanied by copper, because high-dose zinc supplementation can deplete copper over time. A conservative doctor-guided dose is the right approach here. On potassium, if you are on Lisinopril and also taking a potassium supplement or eating a very high potassium diet, or taking other medications that retain potassium, ask your doctor to review the combination specifically. Hyperkalemia is a known risk with ACE inhibitors, and the monitoring for it should be regular, not occasional. Do not stop your Lisinopril. Do not change your potassium intake dramatically on your own. These are conversations to have with your doctor, not decisions to make alone. Tomorrow morning, open your phone and type 4 words, "Has my zinc been tested?" Set a reminder to say those 4 words at your next appointment. That is where this starts. 3 things to carry with you. 1. Lisinopril and other ACE inhibitors work by binding to a zinc-containing enzyme. Research has documented that long-term ACE inhibitor use may gradually deplete zinc levels through increased urinary excretion. Zinc is essential for myelin maintenance and peripheral nerve function. The FDA label for Lisinopril separately lists peripheral neuropathy, including paresthesia and dysesthesia, as a reported adverse nervous system effect. Both facts are established. Both deserve monitoring. 2. ACE inhibitors suppress aldosterone, which causes the kidneys to retain more potassium. In some patients, particularly those also taking potassium supplements or other potassium-sparing medications, this can result in potassium levels at or above the high end of normal, which can disrupt the electrical environment of peripheral nerves and contribute to leg cramps and sensory symptoms. This is not a deficiency, it is an accumulation, and it requires different monitoring. 3. If you have been on an ACE inhibitor for years and you have tingling, burning, or abnormal sensations in your extremities, zinc and potassium are the two specific things to name in your next appointment. Not as alarm, as information. The monitoring that should have been happening may not have been, and 4 words typed in your phone tomorrow morning is how it starts. Before I let you go, something for next week. Everything we have covered so far in this series has been about what medications take. CoQ10 from the statin, magnesium from the PPI or diuretic, B12 from metformin, zinc from the ACE inhibitor, blood flow and circulation from the beta blocker. And in each case, the answer has been the same shape. Understand the mechanism, name the depletion, have the conversation, monitor what needs monitoring. But next week, I want to show you something different. Not a medication, not a depletion, a connection that almost nobody in senior health is talking about between the health of your gut, the function of a specific nerve that runs directly from your brainstem to your abdomen, and the quality of circulation in your legs at night. The vagus nerve, and what happens to it after 60 quietly. Without symptoms you would recognize as nerve-related, that may be one of the most underexplored contributors to nighttime leg symptoms in seniors. Subscribe so you do not miss it. Because if this series has taught you to ask different questions about your prescriptions next week, is going to teach you to ask different questions about your nervous system. I will see you then. Take care of those legs.